Is the slides are visible now?
I'm sorry.
Yes, sir. Yes, sir.
Okay, okay, sir. It's your slide is okay now. Can proceed. I think you can start the meeting now.
We start this session or to be back for a few more minutes.
So did you guys get the screen? My slides?
Yeah, your first.
Yes, yes, sir.
Oh, looks like I'm seeing it now. So how do I advance the screen? You guys do it?
Yeah, I will control. I will control. No issue. You just say the more.
Okay. Am I okay to start now?
So the welcome intro will be for.
Okay, is everybody is cool? Someone Hiran is testing it. Would you like to start my presentation? Hello, everybody.
So we'll start it now, sir. We have an introduction. We'll start it now, sir.
Okay. Let me know.
Sure, sir. Yeah.
Someone is drawing.
Strengthen the practice as well as social commitment through various activities. The 2021 executive members of the association were selected recently. We also had arranged a medical awareness campaign. Sir, is it audible now? Hello? Hello?
Yes.
Do you want to start again?
Yeah, the screen is good. I'm able to look at it. That's not a problem. But it appears the connection seems to be a little breaking up. I want to make sure that everyone is able to hear me clearly.
Sir, your audio is clear, sir.
I'm requesting everyone to mute your audio except the speaker, please.
Yeah, I can hear you now clearly. When the lady talked, it was not very clear and it was breaking up.
Is it clear now, sir?
Yeah,
Yes, I could hear you very clearly.
Shall I start me again?
Yeah,
Okay.
I'm good.
Okay, thank you, sir.
Mhm.
Good evening to one and all. We had a founding stone for Dr. Pharmacy Association in 2017, which includes Pharm D students, graduates, and parents association in Kerala. It is a stage for all pharmacians to strengthen their professional practice as well as social commitment through various activities. The 2021 executive members of the association were selected recently. We also had arranged a medical awareness campaign about the COVID-19 vaccination on 7th July for the Tirunapura Grama Panchayat. The association took an initiative to organize this webinar based on the topic Clinical Pharmacy Practice Approach in the US. To take up the session, we have eminent speaker Dr. Jey Pillai, who have played a vital role in pharmacy field. Now, Moving to the welcome address, now I welcome Dr. Jarin C. Matthew, Executive Clinical Pharmacist of Dr. Rela Institute and Medical Center, Chennai, to deliver the welcome address. We welcome you, sir.
Thank you so much.
Good evening, one and all present here. I'm very happy to be a part of the first international webinar organized by Dr. Pharmacy Association. It gives me immense pleasure to start this webinar by heartily welcome you all. Firstly, I would like to welcome all the office bearers of Dr. Pharmacy Association. I don't know their names, but welcome everyone to this webinar. Secondly, I welcome our eminent speaker, Dr. Jey Pillai from USA, who has been kind enough to accept our invitation to be a part of this webinar. Thank you, sir, and I welcome you to this webinar. Then, I welcome all the graduates and professors who are here today with us. Welcome, everyone. Lastly, the soul of any organization, the students. I welcome all the students to this webinar. I hope it will be a life-changing experience to you all. I'm so happy to see you all before here, and once again, welcome you all. Thank you.
Thank you, Jaren. Is that okay for me to begin my presentation? Hello, is that an S? Can I start?
Hello, sir.
Yes.
I would like to introduce you to the audience.
Okay, sure. Thank you.
Hello, good evening, everyone. It's indeed my privilege to introduce the chief speaker for today's session, Dr. Jey Pillai. He is a pioneer in the field of pharmacy with over 25 years of experience in various facets of pharmacy profession, including clinical, community, compounding, and teaching. He is a board-certified clinical pharmacist currently working at St. Rose Hospital, Siena campus, and he also has his hands in molding Pharm D students in advanced clinical pharmacy practice. He received his B Pharmacy degree from Madurai Medical College, MS in Pharmaceutics from Long Island University, New York, and Pharm D from College of Pharmacy, Pocatello, Idaho. He started his career as a lecturer in KMC University, Manipal, and later he reached his heights of profession in US as clinical pharmacist. With great pleasure, on behalf of Dr. Pharmacy Association Kerala, I welcome you, sir, for the session. Thank you.
Thank you so much for the generous introduction. And if that is okay with you all, I would like to start my presentation now, unless there are anyone else who want to make some remarks before I present.
Start the session now.
Thank you so much, Elizabeth. Appreciate it. I want to thank each and every participant today. Take some time off on a Sunday. It's amazing, and I'm excited. But for the little glitch in the technical arena on which I'm not an expertise. Now, at least you guys are able to see my screen, and someone is going to advance the screen, I presume, as I start speaking with the first screen. I want to thank not only each and every one of you in particular, I want to thank three gentlemen. The first one is Muhammad Waris Ali from Hyderabad, a gentleman I happened to meet in Hyderabad at the Indian Pharmaceutical Congress, who introduced me to another gentleman in Kerala, Prince Thomas Jojo, who discussed my eagerness to talk to you all, introducing clinical pharmacy to Dr. Noble Scaria. And all of these gentlemen made this event, the webinar, possible. I want to thank them. If I don't mention them, it would be negligent of me. So with that little introduction, I would like to begin my presentation, which is a synopsis of clinical pharmacy practice approach in the US. As you know, my name is Jey Pillai. My first name is actually Jay Chandran. When I came to this country, my professor told me, how do I pronounce your first name? It's a long one. I tried to pronounce it slowly, but he didn't get it. But he wanted to condense it as the first three letters of my name so that everyone here will be able to pronounce clearly and easily. And he warned me, if I insist to keep the full first name, my first name is going to be butchered on a daily basis. That's one of the reasons my Jay Chandran became Jay. But you all feel free to call me by the first name if you're comfortable. Second slide, please. Can someone move it to the second slide? Yes. The second slide, of course, is the objective of this webinar is to simply define clinical pharmacy. Most of you would have been aware of the definition of a clinical pharmacy because you have been in this field for a few years, at least by now. Even then, I just want you to indulge me on the definition of a clinical pharmacy, just as a refresher to drive home point, and also the role of a clinical pharmacist and how the clinical pharmacy evolved over the last 40, 50 years in the US. And how do we supplement and enhance our clinical pharmacy practice by utilizing evidence-based medicine. And finally, I will give you some practical examples, a couple of them, that I personally took part and made some interventions on. And finally, I will give you some evidence-based practice tools references so that the students might be able to use it in the classrooms and when they do research, and also the practicing pharmacist will be able to utilize it during their professional course at the hospital setup or even in a community pharmacy. Next slide, please. If you went back to the, yeah, now it's good. Now it's good. If you look at the practice of clinical pharmacy, it has 5 components. I just split the definition of the clinical pharmacy and what it stands for in these 5 different components. If anyone asks us, we should be able to tell clearly that clinical pharmacy is a health science discipline providing direct patient care. While doing direct patient care, clinical pharmacists optimize medication therapy. They not only optimize medication therapy, they tend to provide safe and effective and cost-effective medications. And the final goal is to promote health, wellness, and disease prevention. And this is the whole definition of a clinical pharmacy that everyone must remember. For anyone ask, maybe your friend, maybe your relative, hey, you claim yourself as a clinical pharmacist, what is your role? Because those people, when they go to the drugstore, simply they present a prescription and the pharmacist with a diploma in pharmacy degree, with all due respect, fill the prescription and just dispense the medication. We should be able to tell that's not what we do. We do take part in your healthcare directly when the physician is providing the healthcare for you. So that should be the definition of the new clinical pharmacy approach. And everyone should be able to explain it clearly and succinctly. Next slide, please. If you look at the healthcare team, the healthcare has the patient at the center. That's the nucleus of the healthcare team. Patient care is the most important thing. A patient, it could be you, it could be me, it could be our relative. Usually the healthcare team involves these core players: physicians, nurses, social workers, healthcare managers, physical therapist, occupational therapist, and respiratory therapist. In this healthcare team link, so far, the missing link, an indispensable link, is us, the clinical pharmacist. And without a clinical pharmacist, I believe the circle is incomplete. And thank God, and also thank for the team. I believe in India, IPC worked very hard in including and developing clinical pharmacy in the last 10 years. Next slide, please. Next slide, please. It appears the screen takes some time moving, coming from India to Las Vegas. Yes. What do we do as a clinical pharmacist? If someone asks, what are exactly you're doing when you are put in as a member of a healthcare team, we should be able to say, we are a healthcare provider, no longer a compounder or a pharmacist. We are clinical pharmacist. Physician, the doctor, is a healthcare provider. The nurse is a healthcare provider. And other people in the circle taking part in the healthcare are healthcare providers. And we assume responsibility, particularly in the aspects of medication therapy management. Not only we manage the medication therapy aspect of it, we are the primary source of evidence-based drug information. If someone needs an authentic, high-quality, evidence-based drug information, we are the one they should be reaching to get. And we are also accountable for providing a safe, effective, and cost-efficient therapy. It's not only sufficient if the drug that you selected on behalf of the doctor provides safe and effective therapy, it has got to be cost efficient as well, because most countries in the world, particularly in East Asian countries, they are not very rich. But I will be giving you some of the examples of that in the coming slides. Next slide, please. Thank you. Clinical pharmacy practice duties. As a clinical pharmacist, this is what I do when I go to the hospital on a daily basis. But this is not all inclusive. These are the core functions that I do when I go to the hospital. First, when I go to the hospital, I turn on the computer like you all do. and the physician sitting somewhere in the hospital, on the floor maybe even at home. Now it's being pandemic. A lot of physicians here stay at home and access the computer and do order entries. Our hospital is completely computerized physician entry system. There is no paperwork. And I look at those orders, and those medication orders come to a clinical pharmacist. Of course, he'll be writing a lot of orders, medication orders. He may be ordering labs. He may be ordering diagnostic test, MRI, CT scan, etc. But my part is to skim those orders that are relating to medications. Unless I do verify those orders, those medications, and approve it after checking the following bullet points, medication will not be dispensed. And it is my responsibility to make sure the order that the physician entered into the computer system, he ordered an appropriate drug for the illness he or she is treating, and it is optimally dosed. What does it mean? If I get a prescription order, for example, levofloxacin, one of the fluoroquinolones, and he's prescribing that for an uncomplicated urinary tract infection, you would know that levofloxacin is not an appropriate drug for uncomplicated UTI. Why? There are better drugs. There are cheaper drugs than levofloxacin available. That was number one issue. And then whether it is optimally dosed. Sometimes the drug can be prescribed at a subtherapeutic dose. Sometimes it could have been prescribed as a supratherapeutic dose. For example, the levofloxacin, first of all, needs to be changed to less expensive and more effective drug, such as nitrofurantoin or sulfur drug, Bactrim DS. Levofloxacin has the potential to cause tendon rupture. It can also cause infection in the gut, like Clostridium difficile. It can also cause QT prolongation if it is prescribed to a patient who has cardiac arrhythmias issues. So levofloxacin should first of all be changed to either nitrofurantoin or sulfur drug if the patient is not allergic to sulfur. Even one can prescribe simple, inexpensive ampicillin for uncomplicated simple UTI. For example, if the doctor who knows that levofloxacin is not an ideal drug prescribes, for example, ampicillin, 250 milligrams twice a day, would you dispense it? Probably not. Why? Because the dose is subtherapeutic. For a patient with normal creatinine clearance, ampicillin dose should be 250 milligrams every 6 hours. That's an optimal dosing. So we not only look to make sure the drug prescribed is appropriate, and also we need to make sure it is optimally dosed. And then I would screen for drug-drug or drug-disease interaction. Of course, because of the technology, the software attached to the computer system screen for any of these interactions and display it on the screen. And when we look at it, if it is a really serious, significant drug interaction, then we need to call the doctor to make sure that it is attended to. For example, if the doctor prescribes azithromycin for a patient with community-acquired pneumonia, and the patient is a patient with cardiac abnormalities, who is taking amiodarone, and the screen would display a very severe drug interaction alert between azithromycin and amiodarone. So azithromycin is not a recommended drug. We need to change it with an alternative, such as levaquin, for example, is a good drug. Of course, levaquin also has some interaction potential. So, but a little less than azithromycin. So we got to be careful in monitoring the patient after the drug is prescribed. And then we should look for drug-disease interaction. We would have come across cases where the physician prescribing non-selective beta blockers for patients with asthma. Patients with asthma, if someone prescribes non-selective beta blocker like propranolol, it's going to interact with the disease and it can aggravate the asthma. So we need to suggest a selective beta blocker like atenolol. So that would be an appropriate drug. And then we have to do therapeutic drug monitoring for those drugs with narrow therapeutic index, such as vancomycin, gentamicin, digoxin, and theophylline. And it is our job to order the labs. If the physician has forgotten, we could go ahead and order the labs ourselves. Here in the US, clinical pharmacists are allowed to order labs. They can monitor, they can change the dose. Our hospital system allows that, and we have protocol put in place for that. And cost effectiveness alternatives is extremely important, because if you prescribe levaquin, which is an expensive drug, as opposed to Bactrim or nitrofurantoin for a few pennies or few rupees, that would help a lot, especially for patients who are not rich, who are not able to afford highly expensive medication charges. And then when we do all of this in combination, I'm hearing some background noises. Sorry about that. Looks like the screen is being advanced by someone. Okay, thank you. So when we do these duties diligently, it definitely leads to hospital stay. Number of days the patient spent in the hospital is reduced, and also the overall healthcare cost. Finally, it definitely improves good patient outcome with a quality of life, and patient would respect us, and we will be able to earn their trust. And of course, some good professional satisfaction for ourselves. Next slide, please. Thank you. Need to drink a little bit of water. Apologize for that. Clinical pharmacy is not static, it's dynamic. When I came to this country in the middle of 1980s, the Pharm D program was in its budding stage, just developing, just it is now in India. Pharm D degree at the time was great, and that was an entry point to get into clinical pharmacy practice. Now, after 30, 40 years, it has evolved so much. Pharm D is just not sufficient to get into hospital practice. Nowadays, hospitals prefer Pharm D graduates. Not only Pharm D, they got to have some kind of residencies, PGY1 and PGY2, 2 years of residency after the Pharm D graduation, preferably with a board certification in the specialties that you look at the screen. It has evolved so much that on a yearly basis, the Board of Pharmacy Specialties in the US adding specialties regularly, in addition to what you see on the screen: ambulatory specialty, cardiology, compounding Sterile preparation is something new that was added last year. Critical care pharmacy, if you want to practice in ICU, geriatric pharmacy, infectious disease, nuclear pharmacy, nutritional support, if you want to be an expert in prescribing, ordering TPN, total parenteral nutrition, oncology pharmacy. I believe Dr. Noble Scaria has quite a bit of exposure in oncology pharmacy when I looked at his profile, and pediatric pharmacy and pharmacotherapy. I have been board certified in pharmacotherapy, psychiatric pharmacy, and solid organ transplant pharmacy as well. The Pharm D, I would simply say, is not enough nowadays in the US unless you have these additional added qualifications. It is difficult to get into the hospital setup. And people usually go to work in the community pharmacies, which is not bad. But if you have a passion to work with doctors, physicians, nurses, offering direct patient care, then hospital would be a better place. And that's what I chose. It's like when you go and see a doctor, you will see an MBBS doctor, right? And he or she practices general medicine, internal medicine, family practice. But if you have a cardiac problem, he is going to refer you to a cardiologist. If you have some lung problems, he is going to refer you to a pulmonologist. Likewise, hospitals do have board certified pharmacists with cardiology. So if an internal medicine doctor encounter a patient with cardiac issues, he is going to consult a Pharm D clinical pharmacist with an expertise and specialty in cardiology. If it is clear, I'm going to go to the next slide, please. Beautiful. How do we practice clinical pharmacy? I'm going to talk about a little bit about evidence-based medicine, which adds to the quality of the care that we provide as the drug experts. What is evidence-based medicine? Evidence-based medicine or evidence-based drug therapy literature information combines information derived from peer-reviewed articles, quality articles from quality journals. That does not mean that we purely depend on those information from those articles and journals. We do incorporate individual clinical expertise because years of experience, one has gained a lot of experience. It is not always the theory that we learn works in practice. So individual clinical expertise is extremely important to incorporate with information that we take from peer-reviewed journals and articles. At the same time, we cannot ignore the cultural aspect of a patient, the social aspect of a patient, the religious beliefs of a patient. You've got to incorporate everything together to present an evidence-based medicine. What do I mean by cultural awareness? What do you mean by we need to look at the social background and the religious background of a patient? I have an example. When I was in the hospital, I think a few years ago, there was a patient who belongs to Jehovah's Witness. With all due respect, they are all wonderful people. But when the patient comes into the hospital, they have a belief that they cannot take medications, particularly those drugs that are derived from animals. Those days, I think it's about 10 or 15 years ago when I began the practice, insulin was available derived from pork. And when the patient knew it comes from pork, they refused it. And luckily, at that time, the recombinant insulin, started to become available, and I believe the doctor discussed the importance of taking insulin to control the blood sugar, and we were able to get through a special order the recombinant insulin, which was extremely expensive at the time. That's one example of how important it is to incorporate individual patients' beliefs, cultural background, social background, and religious beliefs. And how do we get these and implement the evidence-based medicine? Let's go to the next slide, please. I'm giving an example of where the evidence-based drug information in this case comes from. Here is an example of the importance of glycemic control in ICU, surgical, medical, and trauma patients. Some of you are practicing pharmacists would have seen patients in these units with the issue of hyperglycemia, very high blood glucose, especially in ICU and trauma patients. And it is important to control the blood sugar because the study shows hyperglycemia has increased mortality, and that's not desirable. So what the physicians started doing those days, they started insulin intensive therapy. That means they started sometimes even insulin drip continuously, aiming for a very tight glycemic control between 80 to 110. And the results were kind of conflicting. In spite of controlling the blood sugar between 80 and 110, there were some patients dying because of hypoglycemia. And the investigation showed, although the blood sugar was 80 to 110, the increased mortality was still occurring. And later on, when the insulin intensive therapy was converted to conventional therapy, meaning insulin given on a sliding scale that some of the practicing pharmacists and some students might be aware of. So they switched over to not very tight glycemic control with a little bit more permissive range between 140 to 180. And that reduced not only the mortality, and also that reduced the hospital stay of the patients. So this information comes from a quality study. I believe it's a randomized control study, nice sugar study. When you get a chance, I have given you the reference at the bottom. You might want to Google it and go through it. This is one example of how to gather evidence-based medical information. Nice sugar study is one. Can I go to the next slide, please? Here is the framework that is in a pyramid form that you might be aware as to how we gather evidence. If you start at the bottom of the pyramid, usually the research study start with an animal research, and then we have the case series or one case report. And then we collect many cases, and then we apply the case control studies. The information coming out of this are not filtered because they are raw data. Raw data meaning they do have human errors, procedural errors. And the person who do these studies might have some biased observations. He would like to see what he wants to see, so his approach would have been biased. So these are all non-filtered research informations. As you go up the ladder, you're aware the cohort studies, the randomized control trials, and also the systematic reviews and the meta-analysis comes at the very top. As you go up the pyramid, as you go into the filtered, areas of the drug information, the quality increases, and the meta-analysis is the one that has the highest quality of evidence. But still, we use any information that is available at the bottom of the pyramid if the top one is not available. That's how we try to gather evidence through this pyramid approach. Can I go to the next slide, please? The evidence-based practice tools, here they are. These are some of the references that are available free. PubMed, some of you would have accessed it. National Guideline Clearinghouse. This particular website gives you the guidelines for individual diseases and drug treatment. TRIP database, and Cochrane Library is very popular for high quality evidence-based information. Next slide, please. These are some other evidence-based practice tools, and we got to pay for it. I think we went one slide ahead. Could we go back to the, yeah, thank you. Yeah, ACP journal, these journals, we got to pay for it. The American College of Physicians Journal, British Medical Journal, and Clinical Pharmacology Journal. And UpToDate.com is the one that I use very often, in addition to Lexicon that you guys would have been using it. And also in conjunction with the UpToDate.com, doctors, they use this a lot because they get good information, not only on the pathophysiology and the disease treatment, how to diagnose the disease, it does give good drug information. So when I go into this, not only I get good drug information, but also look at the pathophysiology, how the doctors approach to diagnose the disease by ordering various diagnostics. So I can see what they see for their practice, and I can think like what they are thinking. That gives me an edge when I get a chance to discuss with them from the point of view of medication therapy management. Next slide, please. Clinical pharmacist intervention. These are a couple of live examples that I personally involved in and made some recommendations, interventions on. If you don't mind, I want to take a sip of my protein drink. I'm a little bit hungry. Sorry about that. It's about 8 o'clock here in the morning, and I believe it's 8:30 p.m. over there. You guys are ready for dinner too. If you want to grab something and eat something, drink something, please feel free. I won't be offended, okay? Yes, let's go into the first example of a clinical intervention that I was involved in. This is an anticoagulant therapy intervention. And I'm giving you just a synopsis of the patient history, because if I give the full patient history, it's going to take too many pages, and we don't have the time either. Already we've spent time on the busting the glitches, so I'm going to be very quick. Here's a pulmonologist treating Mr. John Smith, who is 69-year-old, 65 kilograms, and his height was 70 inches with no allergies. His history of diseases, illnesses were hypertension, COPD, PE with DVT, and chronic kidney disease, stage 4. And his serum creatinine clearance was 3.9. As you can imagine, he is on stage 4. And his INR is 2.8. He is taking warfarin, the brand name is Coumadin, for his DVT, and his INR is optimal. And the pulmonologist is planning for a bronchoscopy for an unclear etiology of pneumonia. I think patient is getting treated for pneumonia, but the X-ray still shows some patches. So So he want to make sure whether it is actually pneumonia or there is some tissue growth in that area on top of the pneumonia. That's the purpose of his planning for a bronchoscopy. So if the doctor wants to do a bronchoscopy, patient is on Coumadin, his INR is 2.8. If he does bronchoscopy at the time of INR being 2.8, he is going to bleed. So the procedure is to hold the warfarin for 5 days at least, because it has got a long half-life. The pulmonologists prefer the INR to be below 1.5. If the warfarin is on hold, then the patient is not getting an anticoagulant treatment. His PE or DVT is going to be an issue. So the process is to bridge, after stopping the Coumadin, to initiate an anticoagulant therapy, usually heparin drip. But this patient, unfortunately, had a previous history of heparin-induced thrombocytopenia that some of you practicing pharmacists would be familiar with. So the pulmonologist is in a bind. He was thinking about ordering enoxaparin 1 milligram per kilogram every 12 hours as an alternative. But the problem is his serum creatinine is 3.9, and the enoxaparin, the brand name is Lovenox, is not recommended when the creatinine clearance is less than 15 ml per minute. So when I was up on the floor, he came to me and asked me, Jay, what do I do? I am in a bind. He needs bridge therapy for 5 days until I finish up my bronchoscopy. I cannot prescribe the enoxaparin because he is renally compromised. His creatinine clearance is 14 ml per minute. And I looked at the literature, and we had another drug that was available for a patient in this situation called argatroban, which is a thrombin inhibitor. Argatroban is not cleared renally, it's cleared hepatically. So in spite of being the kidney function is compromised, argatroban is the only drug that's available for this patient. And we have a protocol for this drug in the pharmacy, which only the clinical pharmacist, I should not say only the clinical pharmacist, maybe sometimes the physicians, they are aware of this protocol. And that's what I initiated. And there is a complete protocol, a page that tells what to do, what is the dose, how to monitor, how to reinitiate the Coumadin or the warfarin when the procedure is complete and the physician wants to go back to Coumadin. How do we transition the argatroban to Coumadin back? This is one of the examples, and I did initiated the argatroban drip. I did monitor the patient promptly on a daily basis, and then I helped transition back to Coumadin. And the pulmonologist was very much impressed by the service provided by the clinical pharmacy department. And from then on, he started bugging me every time, even if there is a simple issue on drug therapy. But it's something that can happen, which is a good thing. So we have got to gain confidence from the clinicians, from the specialists, because you would also face in India, when you get into hospital setup, there is a wall of worry to get through from these physicians. We got to make an impact. We got to project a good image. It begins actually with a good appearance. We got to look professional. We got to look confident. When we present information, it has got to be concise. We got to be polite. We should not be condescending. And also, we should be able to impress upon every physician the importance of drug therapy management is best left to clinical pharmacists. Next slide, please. This is the second example that I was involved in. In this case, actually, the neurologist is the physician. He is a very great neurologist. He's wonderful, but his expertise in treating MRSA wound infection is limited, and he was not comfortable because his specialty is neurologist. And he knows that there is a clinical pharmacist on the floor that he can come to, and I happen to be the one on the floor. He came to me, he told me, Jey, this patient I'm treating for some neurological disorder, and I noticed he has got some wound infection, and it appears he has got MRSA infection. For those of you first-year student not familiar with MRSA, is methicillin-resistant Staph aureus infection. It's a nasty infection. And he noticed it. He came to me, would you be able to prescribe an appropriate antibiotic? And I said, of course. And he was thinking about vancomycin, which is an appropriate drug in this case. And he left it up to me. That's all he said. Could you make sure his MRSA is clear? And then I looked at the patient's history, John Doe, just a very small synoptic information, very snapshot of the patient history. He is 45 years old, relatively young. He's got penicillin allergy. So vancomycin is appropriate. And his height was 72 inches and weighed 68 kilograms. And the serum creatinine clearance is between 80 to 85 mils per minute. And I reviewed the lab as well as a clinical pharmacist. I particularly looked at the wound history, wound culture, and sensitivity. And it showed me that not only his wound culture grows MRSA, the vancomycin minimum inhibitory concentration was 1 milligram per deciliter. So the orders that he initiated was vancomycin 15 milligram per kilogram every 8 hours. As you all know, particularly some of the pharmacists in the audience, that we need to monitor the drug levels for these patients because the trough goal desired is between 15 to 20 for the drug to be able to kill the MRSA. It should not be below 15, which is subtherapeutic. It should not go over 20, then it'll be toxic because of its narrow therapeutic index. So I did order not only the medications, I ordered the labs myself to draw the trough prior to the 4th dose for me to be able to monitor when the drug trough level comes back to make sure it is 15 to 20. If not, I have to adjust the dose. This is one of the consultation that we provided to neurologists when we came along looking for advice on treating a MRSA wound infection with vancomycin. Am I speaking too fast or you guys are tired? If it is, please, one of you let me know. I can quickly go through a couple of more slides and finish up my discussion. Next slide, please. So it's important that we have got to embrace the concept of our being a healthcare provider or a clinician. It's extremely important that we believe that we are the experts in therapeutic use of medications. With all due respect for other healthcare providers, that they do know drug information. They do study pharmacology. but we get a little more deep in not only studying drug information, pharmacology, we also research into literature, and we keep up to date ourselves with the latest drug therapy, drug literature available in the field. And we assume without any hesitation, responsibility and accountability in the spectrum of medication therapy management. We need to consult with other professionals, particularly with confidence. Confidence comes when we gain knowledge. Of course, one cannot know everything about every drug that's available on the market, but we can find and look for that information, and we know where to look for. So it is important we have to embrace this concept wholeheartedly with conviction. Next slide, please. I think I got a couple of more slides, then we can finish up. And if Dr. Noble Scaria allows more time, I'm good with it to stay on the line to answer some questions. Okay. In the absence of evidence-based medicine, what do? Because we don't have evidence-based literature for all the drugs, for all the treatment. Particularly, you would have all known that COVID-19 treatment, it just knew there are not enough drug informations. In those cases, we have got to combine disease-based management, just treat the disease with your clinical expertise and best judgment until such time when the evidence-based medicine comes up and we have to look for it. Next slide, please. Yeah, there is an information glut, like if you're looking for drug informations, this was a study that was done in 1999, 20 years ago. At that time, there were 6 million articles each year printed out, 250,000 to 1 million trials each year. And if you read 2 articles per day, it takes about 82 years. And out of this, the good news is only 15% at the most are useful. So we should be able to know, we should train ourselves to skim the glut of this information and obtain those that are really useful. That is a discussion by itself, but it suffices to say that it's important to throw out those articles that are unfiltered, unuseful, and look for those limited number of articles, which is 1 or 2 articles out of 10, by using those EBM references that I provided. Next slide, please. And of course, just to finish up the discussion, we all know the pharmacy is evolving globally, particularly our profession, clinical pharmacy. And of course, change is inevitable, and we have got to embrace the concept of change. And not all of us are ready for change, because some of us at times resist changes because we tend to ask, what's wrong with the old approach? Old approach is good, but when the new information comes in, if you embrace it, we will be able to provide a better and quality-oriented healthcare, particularly in our case, with a quality drug information and quality drug therapy treatment as a clinical pharmacist. That would be my submission to you guys today. And I do apologize on the time that has been went out of whack because of some glitches that I was not able to share my screen through Zoom. Maybe it's on my side, may not be on your side. That completes my submission, and I do thank for each and every participant for being patient. Some of you might be feeling sleepy. Go ahead and have your dinner, and you all have a good night, unless Dr. Noble-Scaria want to initiate some questions, comments. If you have some comments, please feel free to ask me. If you have some other questions, doubts, help that comes along, maybe tomorrow or next week, there's an email here. Feel free to contact me. I will do my best to help you out. If there are some questions, I'm here. It's morning for me. I can stay as long as you want. I will leave it up to your discretion. Thank you so much. I'm looking at the chat window. There are some questions.
So for an informative session, you have enlightened us by sharing your experiences in the field of role of clinical pharmacist.
Your voice is not audible.
Yeah.
I think some network issue, or maybe using headsets.
Yeah. I think at the chat window, there are some questions. Let me address them first.
Janice Jackson is asking, what are the things we have to keep in mind while dealing with an antibiotic resistance during clinical rounds?
Antibiotics. Antibiotics, some of the antibiotics, they have narrow therapeutic indexes, right? Is that Nazim? Jasmine? Okay. In the slides we discussed, vancomycin is one of them, which has a narrow therapeutic index. And also there are aminoglycosides like gentamicin, tobramycin, kanamycin. Those are antibiotics used in conjunction with vancomycin when there is a gram-negative infection. We need to be careful that we dose them based on patient's weight. Vancomycin, for example, is based on usually total body weight. That's what we did in our patient case. And gentamicin and tobramycin, we should dose it based on adjusted body weight. If the actual body weight is less than adjusted body weight, then go with the actual body weight. Then we have got to order the levels, the trough levels. Vancomycin requires only trough to be monitored, and gentamicin, tobramycin, kanamycin, they should be monitored both with trough and the peak levels. Of course, those pharmacists in the audience practicing, it's not new to them. It's for those who are at the student level, particularly. Those are my suggestions when you guys deal with antibiotics. And I'm not sure I understood the question fully. And the person who asked the question may email me with a particular inquiry, so that I'll be able to look it up and respond better.
Thank you, sir. Thank you for the answer. We have got one more question in the chat box. Not one more, actually similar questions. That is from Rishika. Sir, is it possible if we have completed Pharm D from India, we can work in US? We have got similar questions like that.
I do see that. Appreciate that. Let's see, on that question, right? If you have a Pharm D in India, I'm not an expert in the rules and law of the US, but my best answer would be, may not be a correct one, is that one has to gain entry into the US, which means you have to have a visa. Unless you have a valid visa and a work permit, the immigration and the companies will not select those individuals, even if they are qualified. So the best option is probably to gain entry as a student, on student visa, maybe with a Pharm D, in your possession. And the Pharm D degree, I'm not sure it is approved by the Pharmacy Council. You need to appear for the licensing exam, although you have a Pharm D degree, and you have to pass the exam. And every state has got a different pharmacy council, and every state has got different regulation. In my case, when I came here back in the 1980s, New York State was the only state that was allowing pharmacy graduate from India to appear for the licensing exam. And I was lucky at the time with my bachelor in pharmacy degree from Madurai, with my experience as a lecturer and a pharmacist in Abu Dhabi. I came over to New York City, and they told me, we will allow you to appear for the exam, but you got to have 2,500 hours of training, as an intern, either in a hospital or drugstore or some sort. So I did that. That 2,500 hours, I think it took a little more than a year that I did. Then I took the exam, and I was fortunate to get the license. But at this time, I'm not sure New York City is still allowing foreign graduates. So gaining entry into the US is number one. Number two, getting the license from the state is number two. And I see some of the graduates from Pharm D with masters in pharmacy coming to Vegas. I met a couple of pharmacy students in my hospital. They had masters in pharmacy, and they came over to one of the universities here. They joined Pharm D program. I think it is some kind of a condensed Pharm D for them, some university allows. And they get the Pharm D, they got the license. Now they start to practice as a pharmacist. I'm not sure I gave you a good information, but I believe the Pharm D graduates from India might be able to get the board certifications, the pharmacy specialty board, the BPS allows Pharm D graduates and pharmacists from other countries to take the exam, I believe remotely. So that might add some good qualification color to your experience. I think that would be my best answer that I can give at this point.
Okay, sir. So we have got one more question in the chat box. It's from Veena. She's asking that she was particularly interested in the board certified specialties you were talking about. Could you please give few details of specializations in pharmacotherapy? How is it different from the rest of the specialties?
Oh, okay, that's a good question. Pharmacotherapy is like equivalent to a physician practicing internal medicine. There are some noises. Someone is unmuted the phone, I guess. It's good now. The pharmacotherapy, the board certification I have, is a general overview of the expertise in drug therapy. You can probably equate pharmacotherapy to the medical doctor who has a general practice. And I am good at internal medicine. I don't have the expertise in oncology. I noticed one of the questions here is about oncology from
Yes, sir. It's from Naman.
Naman, okay. I do see that. Here, there is a board certification in oncology, which is called as BCOP, which is a tough exam from my point of view. But we have a lot of BCOP pharmacists, oncology board certified, working only in oncology patients. When you get those specialty certification, then they get to work only on those patients. It's kind of narrowed down to that expertise in oncology, drug therapy management. They don't come to the regular floors. I believe Noble Scaria has an expertise in oncology over there. He has some exposure that I understand in oncology. If there's an oncology question comes to me, if I know, then I would attend that intervention. If not, I would refer that question to an oncology pharmacist. The question from Naaman, and I think that answered the question.
Okay, so the next question from the chat box is that, is there any databases that we can use during the clinical rotations? I think you have already mentioned few while you were talking. Can you add more to that?
Absolutely. What I use personally in my hospital, I use Lexicom. I'm sure it's available over there to Lexicom, which gives good drug information. But the next thing I use on a daily basis is UpToDate.com. UpToDate.com is a composite drug information site where it gives clinical information for the physicians, nurses, and the pharmacist. That seems to be one of the very useful sites that I found in my practice that I refer very often, UpToDate.com. And of course, when you do research, when you're a student, if you write some articles, then you got to refer PubMed for different research articles. You have to look at the Cochrane Library for evidence-based information, and even Pharmacotherapy Journal from American College of Clinical Pharmacy is a useful tool. It's a place where you see all experienced clinical pharmacists from all over the country involved and do some good research, good articles, and that'll be a good place to get some good information. Someone asked me another question, I believe, can we use both vancomycin, excuse me, and teicoplanin? I don't know what teicoplanin is. Teicoplanin. Let me see if I can Google it. What is teicoplanin is? Unless the person who asked me the question, ASW, explain what kind of drug is that? teicoplanin. Teicoplanin is an antibiotic used in the prophylaxis and treatment of gram-positive infection, including methicillin-resistant organism. Good question. We don't have this drug in the US, but I'm glad I learned this from one of the participants. It appears from a cursory look at this antibiotic. It's a glycopeptide antibiotic. It's very similar to vancomycin. So it's not recommended that we use them together. There is no reason to use them together because it appears they are from the same class. If you want to treat MRSA infection, vancomycin alone would be sufficient, or the teicoplanin alone would be sufficient. Combination of this would be redundant, and it would be a duplicate therapy, in my judgment, when I looked at it for the first time.
Okay, sir. The next question in the chat box is,
One of them,
hello?
please go ahead.
Okay, so one of them is asking that after Pharm D, MS in pharmacoeconomics in USA is a good choice or not on future basis?
Yes, from Hiran Divani. Yes, Pharm D, after Pharm D, master's in pharmacoeconomics, not only in the US, I think it'll be a good topic specialty because that helps us cut down the healthcare cost, particularly in expensive drugs. For example, in the case of treating MRSA infection, we prefer inexpensive vancomycin as opposed to expensive drugs. Maybe teicoplanin that we talked about is expensive. And also there are other drugs like linezolid, Zyvox is very expensive. Vancomycin is a few dollars when compared to Zyvox. So pharmacoeconomics would be a good choice, but I'm not sure that I see very many Pharm D graduates with pharmacoeconomics, a specialty here in the USA. Pharm D graduates tend to do residencies, PGY 1 and 2, and then they get those board certifications, whichever the area they're interested in. So that's the way they go. Once they do the Pharm D and all these residencies and the board certifications, I'm not seeing a lot of them doing any specialty courses like this in masters, but they try to get MBA, Masters in Business Administration, because when they become a director of a hospital in charge of a department, business management skills would be a complement to a Pharm D degree.
Okay, sir. Yes. The next question from the chat box is from Saumya. She wants to know, how can we know if an article is useful or not, since only 15% at most are useful?
Excellent question. I believe it takes some experience, and as you start reviewing or start looking at the literature, you will know that the randomized control study is absent. The quality of the statistical applications is lacking. As long as you see the articles in peer-reviewed journals, you can be pretty much confident that you are getting good information. Like, pharmacotherapy journal from ACCP from here, New England Journal of Medications, British medical journals. India too, I think there is Indian Institute of Medical Journals, those kinds of peer-reviewed journals and articles would be the way to go. Not the case studies, case report, even some of the cohort studies, they lack those rigorous study principles. Good question.
Okay, so the next question is from Marcia. She wants to know that the difference between, the drawbacks of community pharmacy and clinical pharmacy in US. And she also would love to know which is more preferable according to you.
Good question. Like I said, there are no drawbacks actually, whether you practice in a hospital setting or in a drugstore setting. It's all our preferences. I preferred to work in hospital settings because initially when I start to become a pharmacist back in New York City, I did work in a couple of drugstores, and that was not my cup of tea that I realized, because drugstore duties involve mostly filling prescriptions. Of course, the system screens for drug interactions. We try to call the doctors, and it is always difficult to get through the doctors. Patients are not happy. The clinical functions are not as great as you can do in a hospital setting. And I found myself that drugstore is not compatible, is not to the liking for me at least. So I tried the hospital at the same time back in Washington, D.C. area. And I liked it because we have the opportunity to intervene more. We can apply more clinical pharmacy than limiting ourselves to prescription dispensing, and also the issue of insurance that comes in. Some of the drugs are covered, and we are not responsible for the coverage, but the patients would be upset if some drugs are covered and you give the bad news to them. So there's no drawback. A lot of people like drugstore setup because they're accustomed to that, and they may not want to involve in hospital setting because it might be a little bit more challenging. Thank you.
Thank you, sir. I have found Swaraj has raised his hand. You can unmute yourself and ask the question.
Good evening, sir.
Hello, how are you?
I'm good, sir. How are you, sir?
Good, Shivaraj.
Sir, I want to know if the student wants to pursue MHA or MBA, like after Pharm D in USA, is it very much necessary to clear the NAPLEX to work in the administration of the hospital?
I believe NAPLEX is required even now if you want to get admission into the university to begin with, right? Once you get admission and get MBA, employment will not require and they don't see whether you took Naplex or not. As long you have the approved, recognized degree and the paperwork, eligibility to work in any company, one should be able to do it. So I don't think Naplex is an issue to get a job in the hospital or in a drugstore setup. It's only needed to get an admission, because when I got my master's degree admission in Brooklyn, New York, they wanted me to show the score of the Naplex. Is that the question?
Yeah, sir. Sir, and if at all the student wants to go to the industry side, like apart from the hospital, what are the master courses the students be doing it?
Yes, in fact, my master's, when I came here, the admission given to me was master's in clinical pharmacy. That's what I began when I came to the university in Brooklyn, Long Island University. I took a semester where I was exposed to many different clinical pharmacy subjects, which was totally new for me coming from India those days. And then I thought, what happens if I go back to India? You know, those days in the mid 1980s, 90s, there was no hospital pharmacy there, clinical pharmacy there. I may not get a job. So I asked my professor, sir, would you allow me to take industrial pharmacy concentration, and explain the reason to that. And he agreed to let me switch my specialty. So my master's degree is in industrial pharmacy concentration. And of course, we did some research. It was on a thesis basis. But I happened to settle down here, and that degree is there, but now I'm a clinical pharmacist. But it comes handy for me as a clinical pharmacist to my colleagues when they have some questions on the formulation aspect, and the questions on compounding certain things. Compounding sterile product is a new thing in the US in the last couple of years, because there are some drugs becomes unavailable, critical drugs that are used in ICU setup, like succinylcholine, like epinephrine. For some reason, some of the manufacturers don't make it anymore because they are not profitable, maybe. So how do we make those drugs? By compounding it, because the raw material is available. We get the raw material, how to sterilize it, how to filter it, what to add for stability purpose. So it comes handy in our sterile clean room area. And I look like, you know, someone like a king when they ask me those questions. So you could do a master's in industrial pharmacy. There are plenty of courses available for those who come here and do those.
Okay.
Yes, sir. Thank you very much, sir.
You're welcome.
Okay. Is it Dr. Gautam? Do you like to ask anything? Okay, so we have so many questions in the chat box, but
yes,
unfortunately,
that's what I do. That's what I do. People who want to stay, please stay. You know, I will stay here as long as you want it. Those people who want to leave the meeting, please feel free to do so. I won't be offended at all. And I thank everyone.
I think it's time to wind up the Q&A session because the time is not permitting us. And I request all the audience to personally email your queries to Jey sir's email. He will definitely clear it out. And okay, I would like to hear feedback from any of you, any of the audience. Please feel free to unmute.
Thank you so much. Unless anyone else wants to make a comment.
Thank you so much, sir, for this webinar. It was really informative and it was really helpful to me. Thank you very much.
Sure. Thank you so much.
Anyone else would love to say feedback? Okay, so let's wind up. Now I welcome Dr. Anne Kurivilla, clinical pharmacist, lecturer, and preceptor to deliver the vote of thanks.
So a good evening to one and all present, and good morning to Jey. It was indeed a great pleasure to attend your session. I was really looking forward to it once Dr. Joel and Dr. Noble had asked me to propose the vote of thanks, and I take a great privilege to sit in front of you and interact with you, Jey. And despite all the sessions, I think your life, you have gone through all the pharmacy life is itself an inspiration to all of us, from where you have started and where you have ended. So you definitely through your life, you say that sky is just the limit, Jey, and hats off for that, because it is indeed your perseverance and dedication that has led you to this state. And behind all this, we have a lot of hands, and I would like to thank all of them with the names. And I hope Jey is not hungry. Can I take some time, Jey?
Absolutely, absolutely. I'm not hungry.
Thank you
so much. Is that Anne Kurivilla?
Yeah, I am. Okay. Yeah, I'm Anne.
Okay.
Yes, sir. And all of that you have shared was really informative, and I hope that all this can be imbibed by all the budding young pharmacists who had attended this session, sir. And all the perspectives we would look into, and as you said, change is a universal law, and even though things are not it's just in the infancy in India, let us all join hands to go forward. And we really believe that you would be there with the Pharm D Association with all your support. We do expect that, and I believe that this association is just the beginning, okay, with this session, and you would be there throughout with our journey. So moving on to all who has contributed a lot towards how this session was going to happen. To begin with, I would like to thank Prince Thomas Jojo, as you had mentioned, Jey, about him. Yeah, and he is a student from the Nirmala College of Pharmacy from Muatupura, and he had coordinated the whole program from the student side. So thank you, Prince. And as you mentioned, Mohammed Waris Ali is a person who helped us to contact you. So a big thanks to Mohammed Waris Ali. And moving on to the others who helped us in this smooth contact without a glitch is Govind from Devika Ammal College of Pharmacy, and Alvin Anto and Martin Baby John from Nirmala College of Pharmacy, Muatupura, and Janice Jackson, Abhijit Radhakrishnan from KVM College, Alipi, and Ashwajit SS from Pushpagiri College of Pharmacy, who helped in the smooth conduct so that the venture went into a great success, as I believe, and as all of us has witnessed. And we cannot thank enough to the coordinators of DOPA, namely to say Dr. Noble, Dr. Chippy, Dr. Elizabeth, and Dr. Joel, who strived a lot and gave a pillar of support to all the students for this to happen. And I would like to thank Amla Joseph from St. James College of Pharmacy, Chalakudi, and Suleika Abdul Karim from Nirmala College of Pharmacy, who took us brilliantly throughout the session smoothly and gave us a brief note on whatever was happening and brilliantly maintained and managed with the Q&A session. And last but not the least, I would like to thank all the delegates who joined us today evening, and whoever, if we have missed out anyone's names and who are involved in this directly or indirectly, without whom this event would have been a standstill. So with your permission, thank you all and have a wonderful evening. And Jey, once again, have a wonderful and blessed morning.
Thank you so
Thank
much, and appreciate the completion of the webinar presentation with your
Thank you,
wonderful,
sir. Thank you.
wonderful conclusion, and the speech is very good. And if I can help you guys any way we can, and if there is an opportunity for future webinars, and if you have any topic that I can handle it, if it is within the realm of my specialty, please feel free to suggest those topics. And if I don't have the expertise on those topics, I might be able to find some of my colleagues and bring them on board. And I got to make sure next time, before I get in the webinar, how to clear up these glitches so that it can go a little bit more smooth. But I do appreciate those people, is that Govind, who intervened and cleared up the glitches. And I'm not a techie. I'm not very good on this technology. There are some issues, I believe, but we will take care of the next time if there's an opportunity. I do appreciate that. I thank each and every one of you for staying so late. And every one of you have got a very good night. Thank you so much.
Thank you, sir. It's a great pleasure.
Thank you, sir, and thank you, Dr. Ann, for your kind words. Now we have reached the end of the session. So I thank everyone for your kind cooperation. And one more thing, I request the participants to fill the feedback form before you leave the session in order to receive the e-certificates. So thank you, everyone. Thank you for joining and have a nice day. Thank you.
Thank you. Good night.
Good morning, sir.
Good morning and good night. Who is this?
I'm
Noble.
Noble.
Hi, Noble. Now I know how you look like. You look better than I. Thank you for organizing it.
So we are requesting you to be advisor for Indian Pharm D, sir. In future activities, all the activities we request your support and guidance.
Absolutely. I will be visiting India. Usually I come every 2 to 3 years because of the COVID pandemic. Everyone is locked up. And I was planning to visit last year. I couldn't do it. Planning this year, most likely end of this year, if there are flights available from here.